Hi, and welcome to Columbia Conversations and Curbsides, where I have a brief chat with experts about important medical topics. I'm Dr. Jesus Lowe, an endocrinologist here at Columbia, and the thing I love most about working here is that every day I get to work with and learn from renowned experts in their fields. And I invite you to listen in on these conversations. Okay, welcome, Today I have Dr. Jennifer Kuo and Dr. Katie McManus, and we are delighted to have a conversation more formally, I guess. So we see each other informally all the time because we work in the same hallway. But thank you for joining us to talk about Thyroid Awareness Month. So welcome.
Thank you so much for having us. We are honored to be here chatting about this.
Always a pleasure.
Happy New Year to everyone.
Happy New Year, everyone. Okay, well, let's launch ahead. So this is January 2022. If you're listening in later on, just so that we have some context here, this happens to be Thyroid Awareness Month. So can you tell us a little bit about maybe an aspect of thyroid surgery that has changed in the last year?
Well, I would say that I think we are finally embracing a concept that's been around for a few years, kind of percolating, but we're really now embracing this idea that less is more when it comes to thyroid disease and surgical management of thyroid diseases. We have a greater understanding of thyroid cancer. We have a greater understanding of how it behaves and the fact that it actually doesn't behave the same in everyone. And that sometimes for the majority of thyroid cancer, where it's somewhat indolent disease, more surgery is not good for patients and we can actually hurt them. So I think we are fully understanding of that. It is being more embraced and more widely practiced. And there's greater exploration for alternatives to surgery, active surveillance for small, well-differentiated papillary thyroid cancers, as well as some interventional treatment options, image-guided treatment options for benign disease.
I think that's a great point, Jen. And I would just like to add in this topic that has also been kind of percolating just in medicine in general, which is just the idea of individualization of medical treatment. I think that is very, very applicable to the patients that we see for thyroid. And we really have noticed, I think, in the last couple of years, as our technology has advanced with being able to do special molecular testing for thyroid nodules, and with the advent of different approaches to treating thyroid disease, that we really take in a lot of the patient's unique story to decide and discuss the evidence and what is going to be the best path for them, because it may be very different from somebody who has another type of thyroid problem, and their preferences and their concept of what thyroid disease means to them, how it impacts their lives, is going to help us pick the best treatment for them.
That's a really great point. And I think due to technology, sort of an explosion in genomic medicine, this whole idea of personalized medicine is finding its way to all kinds of aspects of medical care, and definitely thyroid is included. Along with that is sort of a generalized push in general medicine toward shared decision making, where maybe 2 or 3 decades ago, the patient-doctor interaction was a little bit, I would say, slightly paternalistic, where the doctor would say what they wanted to, the doctor would make a recommendation and the patient would follow it. Exactly, would basically tell you what to do. And the patient felt like, okay, well, that sounds fine. And they would either agree to do that or maybe not. And now there's so much more decisions to be made together. And a lot of it has to do with exactly what you were saying, Katie, about how would a certain kind of surgery impact your life. Do you want surgery? Is there an option of medical treatment? Is there an option of safe monitoring? So there's so many different things that are now involved, which certainly makes for more involved conversations in the office, but there's certainly a lot more awareness, and patients can be much more informed and happy with the decisions they make because they're making these decisions along with us. And to kind of highlight the idea that there's no one right answer for a lot of things. There are many right answers, and there is a better answer for each person individually. And so that's what we're really learning. So that's great. So Jen, on the topic, we're actually really happy that you're here to talk to us about certain less invasive thyroid treatments. We're happy to have Jennifer Kuo because she has one of the highest volume radiofrequency ablation practices here in the country, I would say. So can you describe what radiofrequency ablation is? We call it RFA, those are the initials. But what is it exactly? Is it kind of like a laser procedure? Can you describe it sort of pretty briefly?
Yeah. So, radiofrequency ablation is really just one of these more image-guided thermal ablation techniques. So it's really using different sorts of energy. So laser is one of them for sure. Radio frequency is another, and there is microwave as well, where basically we are targeting individual nodules and using heat, the application of heat, to destroy the cells within that nodule. And usually the main objective is to destroy the cells, let the body reabsorb those destroyed cells in order to shrink the overall size of the thyroid nodules. So it's really to address benign disease, because as we all know, even benign thyroid nodules grow, and a lot of patients at some point will have some compressive symptoms from these benign nodules.
So what kind of compression symptoms are patients mainly talking about?
Yeah, so oftentimes patients will come in and say that when it's large enough, or in a position where it's sort of by the airway or the esophagus, they'll say that I'm having trouble sleeping. When I lay flat or even when I recline, I feel like I'm choking or like I can't catch my breath. And it's just because this heaviness that they have at the front of their neck that's causing them that sensation. Oftentimes people will say that they're having difficulty swallowing. And it's not so much a pain with swallowing, which is what a lot of people ask, are you having pain with swallowing? It's not painful necessarily, but it's almost like an extra effort has to be made. So people will say, when I swallow something, or especially if I swallow pills, I find that I have to swallow multiple times to get things to go down. And so that's a very common thing that people will report. And also in terms of just changes in voice, that's another thing that people can have if they have any sort of compression on the nerves that control the vocal cords and voice projection. People can also have hoarseness or difficulty projecting as symptoms as well.
Traditionally, we've only been able to offer surgery, but now, when patients ask, can't you just zap it? I can actually say, yes, I can kind of zap it. But it's the key to understanding what all these thermal ablation techniques is able to offer is really just understanding that it's volume reduction and not complete disappearance of the thyroid nodule. And I think that it's a concept that needs to be clear and is not as clear to patients, I think, as would be ideal. So you're still going to have a nodule. You're still going to need ultrasound surveillance. You may need biopsies, and you may need future ablation sessions down the road. And so it's still a commitment as compared to surgery. With surgical resection, that nodule comes out, and you never really have to worry about that nodule again.
That sounds great. So it seems that RFA would be great for a person who's got a nodule that's benign, it's not cancer, but it's growing and growing. And every time it gets re-imaged, it seems to be a little bit bigger. And the patient maybe is thinking about whether to have it removed or whether they'd be happy enough to just, as you say, just zap it and make it smaller. And that would be sort of the decision point to make. Obviously, being able to avoid surgery for a less than 1 hour procedure down the hall could be very, very appealing to a lot of people. So how have people been doing? So you've done a whole bunch of these in the last year. Are people pretty happy with the procedure?
Yeah, Dr. McManus and I have done a total of, I would say, over 150 patients at this point. For RFA alone, and for more cystic thyroid nodules, we prefer to use ethanol ablation when appropriate. So combined, we have over 200 patients in our series, and patients love it. I would say for the most part, their biggest driver, what they're happiest about, is the fact that the nodule is smaller and their compressive symptoms are resolved, and they don't need thyroid hormone medication, and they were able to hold on to their thyroid gland. That I think is an increasingly important concept for a lot of patients. And so the ability to address a problem that's not cancer without surgery has been a very good option for a lot of these patients. And we've had outcomes in terms of volume reduction very similar and on par with what the international experience has been previous to us. And so it does appear, even with our own patients, to be a safe procedure. And patients really do, I think, value having that non-surgical option.
I agree. When I bring up that as an option for people's nodules, when I see my patients with this condition of thyroid nodules, you're absolutely right that an increasing awareness and value is to hold on to my healthy thyroid tissue. Is there a way I can just hold on to my thyroid, but just take care of the nodule? And for many years, I said, well, there's really no such thing as a lumpectomy for a thyroid nodule. Either the whole thyroid's got to come out if it's all over the thyroid, but at least half of the thyroid that is housing the nodule would have to come out with the nodule. And that is a significant concern because patients want to hold on to their thyroid function, especially if it's normal, and they don't want to start sort of a long-term commitment with thyroid medication. So that is definitely one of the benefits of this sort of non-invasive technique, and sort of this booming or ever-growing field of interventional endocrinology. So we're very happy to continue to offer that.
It's funny because it used to be that if a patient's nodule comes back as benign, we say, okay, that's it. And really, then they're like, well, wait a minute though. I'm having trouble with sleeping, laying flat, feeling like I can't breathe or I'm choking. I'm having trouble every time I swallow. I feel like I have to swallow extra times to get food to pass. A lot of patients say that they've noticed when they compare pictures from the past to now that their neck just looks asymmetrical or larger.
Especially on Zoom, now that everyone's staring.
Yeah, especially on Zoom, now that everyone's working from home and able to look at themselves 24/7. People are really noticing these changes. And we used to say, well, really, the only thing that we can do in terms of treating this is to take it out. And if it was more of a fluid-filled nodule or a cystic nodule, we could, of course, drain the fluid out with a needle, but that had a disadvantage of a high rate of recurrence. So thus the beginnings of our ethanol ablation, where we actually inject ethanol into the cavity, the lining of the cyst, to get it to sort of stick together and prevent that refilling of the fluid. But now we find that the conversation gets a lot more nuanced and complex with a benign nodule more than with a cancer, because they really have to weigh their preferences about, well, how do I feel about having an operation and undergoing, although complication rates are very low, undergoing a surgery? How do I feel about having a scar? Of course, there are remote access types of surgery that we can take out thyroid, part of the thyroid, the whole thyroid as well, and avoid a scar. And this is just another interventional endocrinology you can add to the list of options, versus how do I feel about, as Jen had said, kind of this lifetime commitment of, I may need to have another biopsy, I may need to have another ablation in the future. because we're not actually taking out the tissue, we're not actually taking out the nodule. But I think it's funny how it's kind of really transformed from a very brief conversation of, well, if it's bothering you enough, people are like, what's enough? It's bothering me. Now to say, okay, well, there's some more options that we have now.
When you first asked the question, what's changed in the last year? In my head, I was like, I'm doing a lot more talking and a lot less cutting.
Yeah. Yeah.
That's the biggest change in my thyroid surgery world. But definitely for sure. The conversations are so much more complex now.
A lot more talking. And I would agree with that. And I agree that these conversations have really bloomed because there are just that many more options that are becoming more mainstream, especially here at Columbia. So yes, absolutely. A short conversation for benign nodules, which are very, very common and way more common than thyroid cancer. It would just end with everything's okay, it's not cancer, to a much longer and nuanced conversation about, well, do you want to do anything about these nodules, and what are my options? So ethanol ablation, injection of alcohol for those fluid-filled cysts, and then up to radiofrequency ablation for the more solid nodules that are growing, all of which are being done here and very, very successfully. Just a question about RFA. How fast do people notice a difference? Is it instantaneous? Does it take a couple of months, a couple of years?
Very quick. It's actually quite surprising how quick those compressive symptoms really resolve. Patients have been reporting that they feel a difference in terms of the neck pressure, in terms of their swallowing, within a week of the procedure. So it is, and that was actually very surprising to me when we first started to do these and seeing patients in follow-up. So it can be, especially for those patients with pretty significant compressive symptoms at baseline, the difference is pretty quick.
Amazing stuff. Amazing stuff. I'm going to switch gears now. We have been talking about thyroid nodules, things that are benign, that people will have some time to think about the options. But sometimes there is not a lot of time to think about particular options, such as when a patient is pregnant. There are certain situations in pregnancy where we will find that a patient really may need to have thyroid surgery somewhat urgently and possibly even during their pregnancy. This would involve things like large or invasive thyroid cancers, persistent hyperthyroidism, where they are allergic to medications or the medications really are not right for them in pregnancy. How safe is it, and when can a patient get operated on in pregnancy?
Yeah, you just hope that the patient's in their second trimester, because that's the safest time to perform an operation if one is really needed. I'd say that we try not to operate in pregnancy at all, but if absolutely necessary, the second trimester really is the safest time. In the first trimester, you risk there's a high risk of miscarriage. Within the third trimester, there's a high risk of early labor.
Makes sense. So we try not to do it, but if we have to do it, mainly the best time is second trimester, and we certainly have had it safely done. Good. And so I'm just going to wrap this up to say that as an endocrinologist, I work with both of you quite often, and we share a lot of patients, and we get to have a lot of back and forth down the hallway about our patients. And you have a lot of other referring endocrinologists who are more remote and need to communicate with you in other ways. What kind of things would you like your referring doctors, endocrinologists, other doctors to know about endocrine surgery, or how best to collaborate with you?
I think for me, it is important to know that you guys are our partners. We really, especially now that everything is so complex, and as you mentioned before, there is no right answer. It's a team effort. It's shared decision making, not only between the surgeon and the patient, but the surgeon, the patient, and the endocrinologist. And so, I think we really do value your knowledge, your training, your expertise in all the areas that we really have none. And it's important that the decision, whatever decision is made with all of our input in it. And so, I don't, surgeons aren't known as warm, friendly types, but we do really, really value, I think, our partnerships with our medical endocrinology colleagues in the care of our patients. And so I guess I don't say it very often, but that's what I would want you guys to know.
Aw,
We appreciate you.
lovely.
That's, I guess.
We appreciate you. Yes. Yeah.
No, that's absolutely true. I think we're a small part of providing care for the patient. We do a very specific, nuanced part of their treatment plan, and we really value the endocrinologists who know them and many times have been following them for years and really have a good understanding of the patient's disease as well as the patient's preferences and how they want to proceed with their treatment. I always think it's so important to communicate and be sure that everybody's on the same page as far as the decision making and timing of things. That is one of the most important things that we do and that we do as surgeons, is to be sure that we follow up and communicate and let you know our plan, make sure that you agree, and then go forward.
Do I work with the best team ever? This is just wonderful. Absolutely wonderful. And I have to tell you guys that obviously, if I don't have the utmost confidence in sending my patients to the people that are going to get the job done in a reliable way and be smooth sailing all the way through, that we can't do our jobs properly. So you're absolutely right. It's a team effort, and we are privileged that we just sort of have the best that there is out there, and we can confidently tell our patients. I would send my own family to them, and so we are completely confident that you will be in good hands when we send you to our people. I'm happy that both of you are here. Good morning.
Thank you for having us.
Thanks for inviting us onto the Hey Sue podcast.